The lymphatic system is part of our immune system or the lymphatic organ system, but it's listed here as part of your NPLEX review. It would include lymph capillaries, collecting vessels, trunks, and ducts. And its job is to return excessive interstitial fluid back into our venous circulation system. It also provides some immune surveillance, some defense mechanisms, and helping to absorb fat from our small intestine using a specialized structure called a lacteal. Lymph capillaries are the smallest. They are very permeable and they are what is collecting excessive interstitial fluid. They drain into a collecting vessel. These collecting vessels now have valves, and this allows for superficial travel along with veins and deep also with arteries, kind of hijacking their mechanisms of movement. And then there's two major lymphatic ducts that these vessels that have drained into a trunk will drain into. Both of these ducts are going to drain into the venous system at the subclavian and internal jugular junction. The right lymphatic duct drains the upper right quadrant of the body only. Very unique. Okay. The thoracic duct drains everything else. So all the other stuff. The thoracic duct comes or originates at the cisterna chyli at L1 or L2 of the spine. So that's when it starts. Our cardiac lymphatic drainage, there is a subepicardial lymphatic plexus. It's a single vessel and it drains into inferior tracheobronchial lymph nodes. So that's specifically just for the cardiovascular system only. And then lacteals are specialized lymphatic capillaries. They're located in our villi in our small intestine, and they're where fat is absorbed. And so the fat is moved from our enterocytes into lacteals first, and then transported throughout our lymphatic system prior to then getting dumped into our venous system and then making its way eventually to our liver. This is showing kind of the drainage process, showing where the thoracic duct comes into play. And then this is showing essentially where things are being dumped into our venous circulation. The spleen is a lymphoid organ. It's in the left upper quadrant between ribs 9 through 11. It's posterior behind the stomach. It's the largest lymphoid organ. It has a fibrous capsule. It has internal trabecula. There is a hilum on the medial surface where there's this kind of entry-exit of splenic vessels. The parenchyma is made up of white and red pulp. The white pulp, think white blood cells, so it's lymphoid tissue. It's located around a central arteriole and it's doing immune surveillance or activating lymph sites, specifically of blood, right? This is looking at blood. Red pulp is has a venous sinuses and splenic cords, and it's filtering the blood and removing kind of old red blood cells. Its main function is to filter the blood, so removing old red blood cells, removing pathogens, removing debris. It also can activate the immune system by antibody production or lymphocyte activation, and it stores platelets and monocytes, and it can do some erythropoiesis in the fetal life, not in adults. It's supplied by the splenic artery and vein. The splenic artery branches off the celiac trunk, and the splenic vein drains into the portal system, the liver system. Clinically, splenomegaly or asplenia are kind of two clinical conditions. Splenomegaly, if the spleen is removed, infection could take hold, portal hypertension or hematologic disease. And then asplenia, this is essentially risk for encapsulated bacteria, which are a mnemonic for asplenia pathogens, is Shin. That's strep pneumoniae. They all have capsules. H. Haemophilus influenza, or Neisseria meningitidis. And all three of these are what we try to vaccinate for to prevent meningitis. The other lymphoid organ is our thymus. This is located in the superior mediastinum. It's anterior in front of the great vessels and the trachea. And its structure, it has this bilobed structure, and each lobe is divided further into lobules by trabecula. There's a cortex, medulla, and a blood thymus barrier. The cortex has densely packed immature T lymphocytes, which are called thymocytes. The medulla has mature T cells and Hassal's corpuscles. These are essentially these concentric or circular epithelial whorls that are very unique to the thymus histologically. Then there's the blood thymus barrier, which prevents premature antigen exposure to these premature T cells. The goal is to mature our T lymphocytes, our T cells, and have them undergo positive and negative selection. Positive selection is where our T cells recognize our own major histocompatibility complex. They are able to survive because then they're able to actually know how to become activated later. And negative selection is when any T cells that are self-reactive, reacting to our own tissue, are eliminated. And this is central tolerance. We'll also see that thymosin and thymolin are both produced here when this is active, and that helps develop our T cells. Blood-wise, it comes from the branches of the internal thoracic and inferior thyroid arteries, and it has this unique component that we consider involution, meaning that it's mostly active during childhood, largest around puberty, and it progressively gets replaced by fat tissue after puberty because our lymphocyte production goes down or decreases with age, which is essentially immunosenses, where we don't have as much of an immune reaction or immune response as we once did when we were younger. Clinically, there's kind of three clinical conditions to keep in mind with the thymus DiGeorge syndrome. This is where we have thymic aplasia versus splenic aplasia. We have then absent T cells, no good. Severe immunodeficiency can occur. A thymoma is a tumor of the thymus, and this is often associated with myasthenia gravis. And in myasthenia gravis, we have autoantibodies that are produced against our acetylcholine receptors at our neuromuscular junction, therefore affecting our ability to convert a thought of movement into the action of movement. This is the only lymphoid organ that comes from endoderm, and it comes off the third pharyngeal pouch. Every other lymphoid organ is mesoderm derived from like a germ tissue layer. Our tonsils or our Waldeier's ring, these are lymphoid tissue rings at the entrance to the pharynx, and they're doing immune surveillance and kind of keeping in mind, like, okay, what is its ingested material? There are three main tonsillar groups, palatine, pharyngeal, and lingual. The palatine tonsils are lateral to the oropharynx, and they're the most common ones to be removed in a tonsillectomy. Pharyngeal or adenoid tonsils are in the posterior nasopharynx, and then the lingual tonsils are at the base of the tongue. There's also some tubal tonsils near the eustachian tube opening. Structure-wise, there are lymphoid follicles that have germinal centers, so B cell zones, and they also have T cell zones that exist between these follicles. They do have some crypts. These are epithelial invaginations. This is really just to increase surface area to allow for sampling of antigen from our immune cells. And there's no really afferent lymphatic vessels. The simple antigen, or they sample antigens directly from like mucosal surfaces. The palatine and lingual tonsils, based off location, are stratified squamous epithelium, versus our pharyngeal tonsils are ciliated pseudostratified columnar epithelium. They are both fed by the tonsillar branch of the facial artery. That's going to be their main kind of feeder. And clinically, tonsillitis, inflammation or an infection of the tonsils, oftentimes a group A strep infection or strep pyogenes infection. Peritonsillar abscess, this would be a complication of tonsillitis, where a patient has hot potato voice. And they're talking like they have hot potato on their mouth. Okay, that's the best I can do. Tonsillar hypertrophy, oftentimes this would be a swelling of the tonsils that could lead to OSA in kiddos, so OSA younger. And adenoid hypertrophy, oftentimes this could lead to nasal obstruction or even eustachian tube blockage, and that would be a conductive hearing loss condition. We contrast these with lymph nodes. Lymph nodes filter lymph. They have afferent lymphatics, and tonsils sample antigens from the lumen. There's no like feeder from the lymphatic system. So we call tonsils secondary lymphoid organs. They can initiate an adaptive immune response, but they aren't needed for our lymphocyte production itself. Versus the thymus and the spleen are primary lymphoid organs. We need them to produce our lymphocytes. Okay, so we'll pause and I'll come and give you my key takeaways.